Welcome back, everyone. Today, we are turning up the heat, literally. We're diving into the clinical management of burns. Now, I've spent many nights in the ER, and let me tell you, when a burn patient rolls in, it's not just about what you see on the surface. It's about what's happening underneath the hood. Sarah, give us the academic blueprint to get started.
Glad to, Dr. Khan. To understand burns, we have to start with the anatomy of the skin. Remember for your boards, the skin has two primary layers. First, the superficial epidermis, which is a stratified epithelium that flattens as it matures. Below that is the dermis, composed of dense connective tissue containing the machinery, the blood vessels, nerves, and lymphatic vessels.
I love that, the machinery. Think of the epidermis as the high-gloss paint on a car. It looks great and provides a barrier, but the dermis is the actual steel frame. If you just scratch the paint, the car is fine. But once you start warping the steel frame, we're talking about a whole different level of repair. Why does this matter clinically? Because the depth of that warp determines if the patient is going home in a week or staying for a month of surgeries.
Precisely. And the board examiners love to test the classification of depth because it dictates the healing mechanism. A partial thickness burn involves the epidermis and parts of the dermis. The high yield fact here is where the healing comes from. It doesn't just crawl in from the edges of the wound. It actually regenerates from islands within the burn site, specifically from the epidermal appendages.
Wait, islands of healing? That's a great visual. You're talking about the hair follicles and those spiral-shaped sweat glands, right? They're like little underground bunkers that survive the fire on the surface.
Exactly. Sweat glands are the most deeply penetrating structures of the epidermal appendages, often extending all the way into the superficial fascia or subcutaneous tissue. Because they are lined with epithelial cells, even if the surface skin is destroyed, these deep cells can proliferate and repave the area. That's why partial thickness burns can often heal on their own.
But what happens when the fire reaches the bunkers, when we get into full thickness territory?
That's the danger zone. A burn that extends deeper than the sweat glands is a full thickness burn. At this point, you've destroyed all those internal islands of epithelial cells. There is no one left to rebuild from the inside. Healing can only happen from the very edges of the wound, where the healthy skin is.
And that is a clinical disaster. If you're waiting for skin to crawl across a large wound from the edges, you're losing the battle against time. The longer a wound stays open, the more fibrous tissue, scar tissue you get. This leads to contracture, where the skin literally shrinks and pulls, which can lock a joint in place or disfigure a limb. Why does this matter clinically? Because this is where we have to step in as surgeons and provide a graft.
Let's talk about those grafts, because the boards expect you to know the difference between split thickness and full thickness. In a split thickness graft, we remove the epidermis and just the tips of the dermal papillae from a donor site. This is efficient because the donor site still has the deep parts of the hair follicles and sweat glands left behind, so we can heal itself quite easily.
It's like taking a thin slice of bread off the top of a loaf. The loaf is still there and it can grow a new crust. But a full thickness graft is the whole slice, epidermis and the entire dermis. This is the gold standard for areas that need to be durable or look good, like the face or over a joint.
True, but full-thickness grafts are much harder to take. They require a rapid establishment of new circulation from the recipient site to survive. Clinically, you often see these used as pedicle grafts, where a flap of skin is moved but kept attached to its original blood supply until the new home can support it.
I remember a case where I had to explain this to a resident. When you are the doctor of choice in a trauma situation, you're not just looking at the burn, you're looking at the future function. If you don't graft a deep burn quickly, the contracture will be so severe that the patient might lose the use of their hand, even if the skin eventually heals from the edges. We graft to speed up healing and stop that contracture.
And don't forget the physiological signs. A patient with significant burns is often in shock. You'll see them pale with goose flesh, which is actually an overactivity of the sympathetic system, causing the erector pili muscles to contract. It's the body's way of trying to preserve heat and shun blood, but it tells us the system is under extreme stress.
So to wrap this up, think of the skin as a multi-layered defense. If the deep bunkers, the sweat glands and hair follicles are intact, the body can rebuild from within. If those are gone, the doctor of choice has to bring in the reinforcements in the form of a graft to prevent contracture and permanent loss of function.
Perfect summary. High-yield takeaway. Split-thickness grafts leave the appendages behind for donor site repair. Full-thickness grafts take everything and need immediate revascularization. Understand the depth and you'll understand the prognosis.